Welcome to Behind the Sports Medicine Podcast, the podcast that pulls back the curtain on the evolving world of sports science. I'm Andrew Rizza, an athlete trainer with decades of experience in professional, collegiate, and high school sports.
And I'm Cameron Roth, an orthopedic surgeon and a consultant for the Chicago White Sox.
In each episode, we'll explore the real-world challenges and opportunities facing today's human performance professionals.
Our hands-on experience is transforming sports medicine and breaking barriers through innovation and teamwork.
Hey, everybody. Welcome to this week's Behind the Sports Medicine Podcast. Today, I have Garrett Scott Bullock, who is a former professional baseball player, physical therapist, and quantitative epidemiologist, a colleague that I work with right now, who had introduced us virtually, and we started discussing some interest in upper extremity pathology and upper extremity research. So we're going to chat about that today a little bit. Garrett, welcome to the show. I appreciate you taking the time today.
Yeah, thanks for having me.
Can you give the listeners a little bit, maybe more information about yourself?
Yeah, for sure. So I grew up in rural Northeast North Carolina, where I was obsessed with sport, as many people from that region is, particularly. I played all sports, but really baseball, basketball, track and field were my big ones. And I ended up playing collegiate baseball at Wake Forest, and then played professionally for the Houston Astros organizations. After I retired at about age 28, I went to get my physical therapy degree at Duke University and worked in the K-Lab the whole time, working on the sports biomechanics. Following my DPT, being from a rural area, I wanted to get back to rural medicine, where the high needs areas with lack of access, particularly in orthopedic and sports medicine care. And I worked in Southwest Virginia in Pennsylvania County, which is the largest county by landmass and also the least populated by population in Virginia. Following that, I was a Clarendon Scholar at University of Oxford, where I got my doctorate of philosophy in clinical epidemiology and medical statistics. So both in epi and in statistics. And then I've been at Wake Forest ever since. Came back to where it all started, as in the School of Medicine.
That's fantastic.
Where my pivoting of my career really was formed within professional baseball. Some of that was because of the classic story of, I got injured and no one understood why, and kind of all that. But more importantly is, I was the Houston Astros organization, which is still at the forefront from a data analytics perspective. And this is really the beginning of that during my time in the minor leagues. And what really stood out to me, and you'll appreciate this, is that, so I played for the Lexington Legends, which is in Lexington, Kentucky, which is where the Shoulder Institute is, with Ben Kibler and all the scapular work they did. And so all those studies that Kibler published in that 2010 region, I'm a subject in. And I directly saw between all the aggregation of data and how we're using data-driven informed decisions within the Astros organization, but then also seeing Kibler work with all his research studies. And I remember him coming back next spring training after I was getting my shoulder range of motion and checking my scapular traction trajectories and all this. And then the next year he presents. And because of that work, it directly changes how we do throwing and bullpen sessions for that year moving forward. And stuff then, which is now pretty standard, is that we have this trajectory of shoulder recovery from a range of motion and from a scapular movement perspective. And so we actually literally changed in that week how we threw because of that work. And that's what really kind of informed me, this is what I want to do. I want to do direct clinical application research with grounded based within exercise and physical therapy. So
that's pretty amazing. But were you dealing more with the older athlete, collegiate and above, or were you also dealing with adolescent athletes in that research realm?
Yeah. So I would say it was mostly youth. So middle school, high school. I would have some occasional people that would find me on the internet and fly in or drive whatever amount of time. But most of it was, I'm from this county or one or two counties over, and I was recommended to come here, and you're the only PT in about an hour drive. So
yeah. So what were you, as far as prevalence of injury in adolescents, ranging from? I mean, sometimes you look at some of the numbers; it's from 9 years old up.
Yep.
But if you're in that range of that growth and development, what were you seeing the most of? Was it elbow pathology, shoulder pathology? Were you seeing a combination of both?
Yeah, I think from a throwing or overhead athlete, so swimming, tennis, volleyball, it was actually about equal shoulder and elbow. Baseball was probably slightly leaning towards elbow, but I would say from tennis, volleyball, swimming, it was more shoulder. So it ended up being about equal, about 50-50.
What other things were transpiring from that? I mean, we see it all the time. We talk about, the athlete that comes in and they have elbow pain, and after we evaluate them and see them, we know is that they have shoulder girdle weakness, posterior chain weakness of the shoulder. They may start to be experiencing some paresthesia in the hand. So we're looking at, is it thoracic outlet? Is it cervical? What were you seeing? I mean, it's almost like you're putting the cart before the horse? Are you actually identifying the true primary injury versus the secondary injury? What were some of the things you were seeing and teasing out with some of those athletes?
Yeah, so I would say that I would put them into really three buckets. There was a group, and about a third for each one, so 33, 33, and 33%. There's about a third of the athletes that I was practicing and training this much of whatever it is, and then I had this giant spike because of a tournament, or we get back to preseason and I wasn't doing that much, and now coach is making me run or throw triple of what I'm used to. And so we have like a true like spike in acute workload, and I have an overuse injury of some sort. I'd say another third is that the injury is because of biomechanics, dropping my elbow or I'm opening too early. And it's truly like a sport technique issue, a volleyball, I'm arching my back too much or something like that. And then the other third is that I'm having pain, say, in the elbow, but it's really coming from not having parascapular strength, or my lower extremity and my core. I don't really work those at all. I just throw and maybe do a little quote unquote band work, which, so I would say those it really kind of about equal thirds between those three types of athletes for injury pathologies.
Yeah, I mean, it's quite interesting because when we see young kids and they start to throw, if they have any type of accuracy, they're the kid that's going on the mound for Little League, right? Or even for Babe Ruth. I remember growing up playing baseball, that's what would happen. And now there's so much specialization in the sport. If we look at, what else are they doing in sports? Are they doing multiple overhead sports? Or are they just mainly focusing on throwing and pitching for baseball? And then how are we seeing that, mechanical breakdown, but also just physiologically and mentally, what's the breakdown for that athlete? How do we correct that? So it is interesting. We could sit here and dive into it for hours and hours and hours and try to figure out the athlete. But I think it comes down to a lot of the coaching. And then also, is there someone like yourself they can go to in order to make sure they're getting the right care that they need to make sure that they're not injuring themselves worse? Because as you know, being a physical therapist, you're getting them when they're broken. I mean, they're coming in after they went and saw the doctor, and the doctor's like, well, you're 13 years old and you have a apophyseal, fracture, or you have, a UCL tear because you were throwing too many curveballs and you were throwing 100 pitches every third day. And, we're getting all this stuff that we just don't like to see. Were you trying to educate in the area you were in? So if you were getting these people that were coming in, young adolescents or people coming into the clinic, were you trying to go out in the community and educate more? Were you trying to give more information? Like, how did that work within your practice? And what did you see once you started to do that?
Yeah, so I really thought about it in three different aspects of like the patient and the people, the support team, that would come with that patient, if that's parents, coaches, athletic trainer, physician, referrals for that individual injured athlete. Then we had a in-clinic exercise and strength and conditioning program that was run by my physical therapy tech. That was also a CSCS, which was fantastic, it was the cheapest thing you could think of. Sometimes I think it was probably too cheap and people thought it wasn't enough substance because of just to sell the dollar amount, because it's really about just trying to get people in the door. And then finally having education seminars and screening events within the larger county level. Yeah. And having that layered effect, I think really helped. And really building community relationships with coaches, athletic trainers at each of the schools, and then even into the administrative athletic director, principal, superintendent level at the schools was really imperative to help create those pipelines to understand awareness of access, of where to go for access, but then even more importantly of education of like some of the stuff you just do on the field or on the track or on the basketball court during warm up or cool down. It's very simple, and that's probably going to put a big dent in the injuries you're seeing generally.
Now, with the population you're working with, and surgeons in the area, how would they work into this whole process of education? I mean, you obviously have a go-to for your upper extremity orthopedists. Is there a connection there with you, the physical therapist, and or the research team? Like, how are you working together in a way to make sure that they are getting the message across, medically, but also you're working on the mechanical piece of it?
So thinking about like your medical providers beyond your own clinic is really important. And particularly in a sparser population and sparser healthcare access, but also density. And so like one of the things that I did from the minute I moved there was try to go to lunch with every single medical provider that had sent referrals to the clinic. And so in rural communities is as important, if not more important, to go to the GP, because that's where there's more GPs and there's two orthopedic surgeons
specialists,
within
right.
Not even, and those orthopedic surgeons, I would call them very generalists. They kind of do and see everything. And so having those relationships and gaining trust and a rapport that, they feel comfortable calling me and say, hey, patient X, I've referred to you. This is what I'm seeing. See what you think. And then also the reciprocity of me being able to call me, hey, I've seen him for 6 visits. This is what I'm seeing. I think you need to recheck him, or I think he's doing good. And then we kind of see from there. Creating that, I think that is extremely important, particularly in a sparser medical density community.
And that makes you the go-to, right, for the upper extremity pathologies. I think one of the things that's interesting is you have physicians that are in the area, people that you're working with, and like, hey, Garrett actually played baseball. He knows baseball. He's the therapist of choice. He's actually gone on his way to come out and meet with us and our team to make sure that you have a good relationship and a good rapport, so they know where to send people to see. I think the interesting thing is I was talking to Chuck Thigpen, who introduced you and I, and it's the same thing. You have to be able to market yourself as the clinician so people know who you are and who you go to. They might instead of going to Garrett's physical therapy clinic, they're going to a physical therapy clinic to see Garrett, who is a specialist in upper extremity rehabilitation. And I have a really close friend that I went to undergrad with who's now in Louisiana as a physical therapist. He runs a big clinic, Willis Knight Healthcare. He runs their spine clinic, but he also runs a lot of the subsets in the mental health and sports science and athletic training realm. He said, you got to water the grass to grow your grass. He's like, it's plain and simple. If you want to get better at what you do, you have to go out and you have to make yourself available for these people. And it sounds like that's what you did when you were in Virginia. That was like the thing that you had to do to make sure people knew that you were there in order to make things happen. So very important to do for career development, but also so people understand where you are and what you're doing.
Yeah, and even more importantly, beyond that, is just so that the patients get funneled to the right spot. Classically, patients, particularly in these types of communities, are going to go see their quote-unquote doctor or their GP because, I hurt my shoulder, I need to go see the doctor, or my kid hurt their shoulder, I need to take them to the doctor. And then from there, like, are you going to be sent to the physical therapist that's a little farther away that might know more about what this is or have experience personally and then clinically, or are you going to be sent to the one down the street that probably get you back to function, but maybe not to return to sport to where you need to be. And those are getting those patients to the right provider at the right time is really important.
Oh, 100%. Did you find that people were, parents and themselves, I think parents sometimes are the ones that are the extrinsic distractor almost, but I feel like they're the ones that are pushing the kids. The kids want to play baseball, but now they're playing town league, they're playing high school, they're playing club. Now they're playing 12 months out of the year. What's the discussion with that parent on the best interest of that athlete to make sure they perform? Now, you had gone through all of those levels all the way up to professional level. Do you have that side of you that speaks to them as, hey, I made it to professional sports and this is what I had to do, but I also know a little bit better on what you should be doing because I'm now a physical therapist and understand the research, biomechanical, epidemiological side of things. What did that conversation look like?
Yeah, I actually never really played the pro card, to be honest, pro baseball card. I actually really don't like talking about that from a clinical side. I always try to make it more about performance of the athlete and what they're in meeting their goals. So one thing I've learned very quickly, and then experience this myself, is that the parents and then your coaches don't really care about the medicine. Or whatever that means. It's all about getting back and then performing as well or better than before. And the conversations I always have is particularly with parents and coaches, is I always supported and actually tried to get the coaches to come or be on a FaceTime or something during it. If the patient wanted that, if they felt comfortable with that, I should say that, was really talking about okay, this is where you're at, elbow injury, shoulder injury, whatever, forearm injury. And how is this affecting your performance? And they're like, I haven't been able to pitch in 3 months and my elbow hurts and my velocity shot 5 miles per hour. Okay. I said, okay, so this is why this has happened. This is what we need to do to get you back to that level. And then from there, I said, depending on where they are in the season or off season, this is what we need to do to be able to maintain this, if not get better within the next 6 months to meet this goal, which might be making the JV or varsity team if you're in 9th or 10th grade, or it might be trying to get good looks from colleges if you're on the fringe of that level or above for say 9th through 11th grade, and then moving forward. So that's actually where I really focused on. And I felt like for me personally, I'm actually quite shy. I don't like talking about such things. But even more importantly, trying to keep the focus on the patient I think really helped. Now, if they would ask about that, I would tell them, and sometimes that would help improve their buy-in, or they would have fun with that. And then we would throw, and then they would see things. But yeah, I think keeping it on the patient and where they're trying to go was the way that my personal style.
Yeah, we chat about it here and with clinically, and also, we both physical therapy, athlete training. It's about the patient. It's not about you. It's understanding what they are going through and how to change that. I feel like sometimes there's always a good story behind, if you've experienced it, like what I went through, and this is what I had to do to try to make sure that I was improving and getting better. This is probably not too much of a loaded question, but I think that the big thing about it is, so upper extremity pathology in general, so shoulder, elbow, the things we talked about previously. Do you think this is in part to specialization? Is it developmental delays in some athletes? Is it the way they're being coached? Is it them watching videos or highlight reels of their favorite pitcher, or, all the above? Where do you find, or where did you find when practicing, or even in your research, endeavors, where do you see this kind of going, and how do we correct it if it is becoming more of an epidemic with these type of upper extremity injuries?
Yeah, I think this is actually an extremely complicated question and solution. I should say complicated solution. And so what I was talking about is where I start most of my talks is that, starting in really the 90s, and you think about Tom Howells and Ken Wilk and Fleissig, like they started talking about pitch counts and pitching biomechanics, and we need to get rotator cuff peristaltic strength up and like all this stuff, and really started to really get implemented in the late 90s and around 2000. And we thought, as a general community, baseball or sports medicine, that doing these things, we would curtail those injuries, if not at least just keep them where they are, or hopefully move them down. And what we've seen is that they've actually thrown more fuel on the fire, and it just kept going up. Yeah, we're almost at a geometric rate of increasing. And there's different pieces of that, from better imaging and better surgical techniques, which allows for more conducive for that surgery, and then also for interventions on the injury. But there's also a lot from a public health and from a sports science and from a sports medicine perspective that we don't understand. And I really think it's kind of the confluence of kids are less active and they play more. So we have more games and we have less activity. So like I'm not that old, but it's not that long ago that when I came up in high school and middle school, we would play once a week, maybe twice a week in high school. And then, or if we go middle school once a week, we'd have 3 or 4 practices. And then when we're not in practice, we're playing basketball or soccer or flag, touch 2-hand tag football. These kids, they play video games. And then they sit and text their friends or whatever. Yep. And then they go play 5 games in a week, and they do that for 220 days a year.
And they don't have enough pitchers to pitch. So it's like, okay, next up, like, how do we get this to work?
So I think that's a lot of it.
Yeah.
So then we have decreased physical robustness and physical variability of the human body. But then we also have increased workload. So it's both sides of the spectrum.
Yeah. I mean, we have a baseball coach who used to coach with me. He's a friend of mine. He doesn't coach in the town anymore, but he was always saying, I'd like the multi-sport athlete because they have the dynamics of doing different things versus specialization. Even though you're a coach, you really would like your players to just focus on your sport. He was always a proponent of like, play basketball, play football, maybe go out and do some other cross training just so your body can get adapted to other stressors, because the specialization is causing too much. And you alluded to the 1 game a week to 3 to 4 to 5 games a week. And now you're dealing with shortened schedules. You're dealing with rainouts. You're dealing with all this stuff that has to be extrinsic factors you can't control. How do you control that stuff intrinsically to make that athlete understand, hey, this is what we need to make sure that you don't get injured, so we keep you active, you stay healthy, and you feel comfortable doing what you do. I do have to agree. I think kids need to be doing more. When we were growing up, I'm a little bit older than you. I think we used to go out. We used to go out at wake up, have breakfast, leave the house, and come back when it was dark. Our parents were just like, just come home for dinner. And we'd be out all day playing. We, like you said, tag football. We played baseball. We played street hockey. Like, we were doing everything. And I never had any one of my friends that played baseball, even myself, that had shoulder or elbow injuries. So it is quite interesting. Maybe we weren't that good, but also I think we didn't have as many games and practices as you alluded to, where now it's just becoming this metric that is so driven by becoming better that there is this more stress the body can't handle at that age because of development, but also they're not resting as well. They're not eating as well. They're not sleeping as properly as they should be. So there's a lot of components, I think, that makes it very interesting to see how can we dial this back a little bit. And I think that's probably one of the things we're going to get to pretty soon is pitch counts. Like, how do we change that? And this is one of the things that was implemented, which I think was fantastic. The younger ages having pitch counts and rest days in between, specifically to reduce the rate of injury.
Yep. And, I think those pitch counts are a great start. It gives you a hard stop sign of like, you throw this many pitches, you have to have this many days. Now, the thing about it, though, is that, you could have a league that does it. Like, so Little League does this, the Little League International, which has been it was controversial when they put it in, and it's been very good. But kids don't just play one league. They play Little League, and then they have the travel team, and then they have their AAU team, or whatever, or they play school ball plus travel ball or whatever. And then most parents, almost all parents, are not going to really know or regulate. Oh, player X has pitched 3 innings in this league, so he needs to have that no matter what team he's playing for. They just think about it like, okay, for that team he can't pitch for 3 days or 4 days or 5 days, whatever amount. But then he's going to go pitch on the other team or go play catcher for the other team or shortstop.
Right. He's throwing even further. Yeah.
Yeah. So like, it's not pitching, but you're still, catcher throws as much as the pitcher, like literally.
And from a kneeling position.
Shortstop's making multi-angle throws to second or first majority and across the diamond at maximum effort on the run a lot of times too. And so that's like another level of stress.
Correct. And interestingly enough, I for reference, we had talked about or looked over the pitch counts what basically Major League Baseball, USA Baseball had put out, and if you look through some of the criteria for what you should be following, it really doesn't say anything related to what about warm-ups in between innings or bullpen before playing. And then again, you said if they go from pitching to another position during a game where they get taken out, now they're going to shortstop or they're going to catcher or they're going to go to the outfield. They're still making those throws. And I think the important piece to this is, I don't know if it's ever going to happen, is for all of the leagues to have some type of cross transitional reference for these kids, like a league, some type of software that they can actually have to put in every single week where that athlete was playing and how many throws they had in order to be able to curb some of this. But again, it's, what's more important for the athlete? Are they like playing town ball? Are they like playing for their travel team? And it really becomes like one of those things. How do you make that decision, and how do you make sure the athlete's safe?
Yeah. And I think a lot of this comes from the pressure of trying to get a college scholarship now. Undergrad tuition, all tuition, but undergrad tuition is what parents think about when they're middle school or high school or even elementary school. It's getting higher and higher. And then the amount of scholarships is getting more competitive. Mm-hmm. And so I think a lot of this is driven in that realm. And then with NIL, it takes it to another level again, because of now you can get a scholarship and get money in your pocket at the same time. So I think a lot of that pressure is really because of that. And parents, people don't have that experience or knowledge base. They hear these different teams or different people or different saying like, well, you need to play on my team or this league at 11 to then get ready for high school, which will get you a college scholarship. And in reality, like, it doesn't matter what you do at 11, what team you're playing for, as long as you're getting the skills in, learning the fundamentals, and not getting injured, then you're fine at 11 or 12. But they don't know, and then there's just more and more pressure for that area. Yeah,
I know some of the research is, and I think you've done some of this on the size of the ball. I've never really thought about the size of the ball. Right? We look at distance, different ages, right? 45 feet and 60 feet. How does the size of the ball correlate to what we're seeing with injury?
Yes. So this comes out of the National Coaches Association came to us and wanted to work on this. National Baseball Coaches Association, because like in other sports, and so like in tennis or in basketball, or the two that come to mind, or golf, is that when you're 8 years old, the size of your implement and or ball is different than when you're an adult. Baseball is one of the only sports where the size of the baseball doesn't change. And I remember being 7 and having to grab it with my entire hand and throwing it. And then when I could hold 2 fingers, it was weird. And then it took a while to figure that out. And then when you get to about 13 to 15, you can actually, in your hand, it actually feels like you can manipulate it with 2 fingers. And so wanted to understand what are the biomechanical implications of using a smaller ball, either weight and or size, with youth athletes, because their hands are smaller. So some of the hypotheses are, if they have a ball they can hold with 2 fingers that they feel comfortable with in their hand size, maybe they can manipulate it better, and then be able to throw more strikes. So if you throw more strikes, there's less pitches, and then you have less pitching exposure. And then also bigger ball is heavier, and you have to maybe alter your mechanics, and maybe you have better mechanics during that phase too. So we've only done some of the cross-sectional biomechanical work in this, and we found is that and this published in the American Journal of Sports Medicine, is that cross-sectionally with youth, like under 12 athletes, randomized to which ball they're using per throw off the mound, there's no difference in the biomechanics. So like from a kinematics, so where your arm and how the arm moves in space, and then kinetics, the force is going to your elbow and shoulder. So that's a really promising sign, because, with all the weighted ball training, there's the heavier ball and the lighter ball to try to help you get faster pitching velocity. So one of our worries is that what if the lighter ball makes you have faster arm speed, does higher kinetics to your elbow? So you're actually putting more stress on your elbow. Then with the lighter ball, it might be better to use, but you're actually putting more stress. But we did not find that. So the next phase is just to look at that longitudinally, because the next question is like, all right, so we use this one time and it looks the same, but what happens if we use it for a whole season? Do the mechanics get better, like more efficient because they can actually hold the ball in their hand with two fingers in the right way? Or does it make you actually have worse mechanics or something in between? So
are you seeing a translation from, or even you're looking at like lower extremity strength and mobility in that same cohort of individuals you're researching? Or are you just looking at complete shoulder, upper extremity biomechanics in that subset?
So for that specific study, it was trunk and then in upper extremities, so kinetics and kinematics. Okay. And so, so the kids are actually a little too short and small to be able to reach the force plate. The lower extremity kinetics specifically are not really assessed that much, but we're really looking trunk in there. Moving forward, we're trying to look at the entire body.
Okay. Were you seeing a certain amount of throws in relationship to when they would start to fatigue and drop their elbow? Was that ever looked at, like saying, hey, at 35 pitches with 70% of our population, they would drop in their elbow out of where we would like to see them?
We only did 15 throws to just really look like, does this look the same across? But we have actually done a lot of work that's not out yet with one of my PhD students, is actually looking at individualized fatigue markers from a biomechanical and then also from a pitching performance perspective. So velocity, spin, vertical break, biomechanics from kinetics and kinematics, and then also into psychological factors. And then, this is for collegiate and above, but we've seen that it's actually extremely variable, which is, I mean, if you think about it from classically, like, I think if you think about like guys that get, like, there's certain pitchers in the big leagues that you could throw them every 3 days and throw 125 pitches and they'd be completely fine.
Roger Clemens or Greg Maddux or
Nolan Ryan, like the ultimate iron horse on the mound. And then you have guys like DeGrom, who's like, he throws unbelievable stuff, but he's super fragile.
Yeah.
Yeah.
And you mentioned ball size too. I mean, I remember Pedro pitching and his fingers were so flexible that he could whip the ball. And I think he didn't have to use as much, muscular overpowering of his ball to get his ball to do what he wanted to do because his fingers were so long.
Yeah. Pedro's 5'8", 5'8.5", 155 or something, but his hands were like the size of like a 6'6" person, but his fingers could touch the back of his forearm. Yeah.
It was amazing.
He's made to pitch, man.
Exactly. If you're looking at that study, or you're looking to do a study where you're looking at fatigue factor in the upper ages and it's the professional level, are you focusing on certain pitches? Is it just fastball, curveball, changeup? Is it one pitch? Are you trying to see like, hey, 5 fastballs, 5 curveballs, 5 changeups? What would the variable be there?
Yeah, so we're trying to look at a multifactorial piece, but then we're also looking at an acute, so like one pitching outing. Yeah. So how many pitches before you find fatigue at individual level within one start or one pitching appearance?
Yep.
And then more of the sustained chronic level across the season.
Okay.
There's certain pitchers that, you put them in the starter role and they kind of burn out about 13 to 15 starts.
Yeah.
That was who I was, about 15 starts when I started to lose my stuff. And then there's other pitchers that you throw 30 starts. But if you put those same pitchers that might only throw 15 starts, you put them in the relief and they only have to throw 1 or 2 innings, they can go 30, 40 appearances.
Yep.
And so really trying to get to the individual level of how many pitches in one outing, and then also throughout a season for appearances.
Yeah. So innings pitched versus pitches thrown.
Yep. Yeah. And then trying to understand it from a more of a performance side, as our feedback from our knowledge users, our knowledge user community is that's what they really are more interested in, which I think it plays balance as well from a sports medicine perspective. If their performance is going down, then their injury is probably going hand in hand up. Yeah. So just a little bit difference in terms of the story we're trying to say, so particularly to have better buy-in and implementation to the knowledge users themselves.
What are some of the key exercises if you had to give the population? You have a cohort that is going to be a control versus the athletes that are getting really most of the research focus?
So it's actually based off of the one team,
Yep.
it's off of their game metrics as well.
Okay.
So we have seen a distinct difference in the lab versus the game. So
Okay.
we see a lot of times pitchers throw 100%, and they're legitimately throwing hard as they can, and they're say throwing 90, but then they get in the game, they're 95.
Yeah. Right.
The
right.
adrenaline and all that kind of stuff. So we're using in-game metrics only.
Okay.
And then everyone has their standardized arm care and strength and conditioning program since they're on one team.
Mm-hmm.
And the interesting thing about this, which is called N of 1 models or nomothetic models, is that it's for each individual person, and then they just need a certain amount of appearances to be in, which I think they said was 11 or 12.
Okay.
Through my simulation work. So I would say actually their arm care and their strength and conditioning is all standardized. They're all getting the same thing.
Yeah, it's one of the things we talk about with the young athletes. They want to do heavy, 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 heavy. And we're like, you know what? If you ever go to a Major League Baseball game and go watch what they're doing in the bullpen, the yellow, red bands they're doing, and they're probably doing throwers 10 exercises on the side. And that's what they basically do to educate them enough to try to stay strong. But you also have to do trunk and lower extremity work, and they don't like to do that stuff.
Yeah.
That's what's important for them to understand, like what they need to do. What type of technology is being used in the capture? Is it GPS capture? Is it machine learning type capture where you don't need to, like, you can just video analysis the thrower to see the mechanical pieces of the analysis? How is that being translated down to you, the researcher?
Yeah, so in multiple different ways. So one is that we're using TrackMan, which is radar based, and then we have Kinetrax, which is markerless motion capture on field, and then we've also been working with Marker inside the lab with TrackMan to understand, how much of this is an apples to apples, versus an apples versus an orange, or a Granny Smith versus a Gala.
Right.
And so we did that work beginning with, and now we're really looking at it from a seasonal perspective.
Yeah. It's pretty cool stuff. I mean, I saw the markerless getting my master's, and I was like blown away. Like even the machine learning, me going through a pitching motion, and it picked up my biomechanical deficits. I was like, this is like the most amazing thing compared to having to put dots on every little part that was going to move, right? So markered versus markerless. And I think it's interesting to see if you have that available in your community. If you have somebody to send, your athlete to be able to do this analysis is pretty amazing. And you can do it pretty much inexpensively, I think, in the grand scheme of things of what it used to be when it first came out.
It's definitely a lot easier to access. I would say that what's called deep learning neural nets for this markerless motion capture technology definitely is noisier and doesn't have the precision of the 3D marker, but I think the definitely usability and then the reach is definitely larger. So you're kind of balancing both. And I think just understanding what the limitations of that technology is versus the gold standard. But yeah, I think for within the weight team, they use markerless all the time. And then we will reference with the markered for specific captures in the year to kind of understand where they're going and if that's really the signal we're seeing.
Yeah, that's great. I know for us here in Massachusetts, we have the McKaylee Center for Sports Injury Performance or Prevention. They're in Boston, right outside of Boston. Dr. McKaylee was one of the first sports medicine physicians in the country that really pioneered sports medicine. They started this center, and they have PT, they have sports science, like analytics there. They do a lot of biomechanical analysis and kinematic analysis. Is that something in your region where they have that type of center available for the young athletes if they needed to come in and do that type of analysis? Or is this more of instead of a preventative model, more of a research-based model?
Yeah, so the pitching lab, the Wayforce pitching lab is really holds three hats. One is true applied in-house sports science for the Wake Forest baseball team, and mostly for pitching, but also for hitting. We're doing more and more hitting. Number two is actually community outreach. So anyone from the community, and community as can be anyone from the world, to be honest, can come and be evaluated. And it's the same evaluation we get to the Wake Forest pitchers or the Wake Forest baseball team. And then three, it's a research lab. And some of that stuff overlaps between all three, and some of it is very different with different goals. And trying to balance that is very, very fun and actually very impactful because they kind of feed each way. So like something we're seeing in the pitchers of the Wake team might cause us to have a question to try to answer from a scientific perspective. And then, or vice versa, we find something from the scientific perspective, and then we try to, truly implement it from a community and or Wake Forest baseball perspective.
Yeah, that's pretty amazing that you guys have that available. And I think you see more and more that I think across the country at research organizations or research institutes where, we have to just do more research. That's the only way we're going to get better. So that being said, where's the research heading? So we talked a little bit about, pitch counts, talked about ball size, like what's up next?
Yeah, I think there's three things. I feel like I'm saying three every time, but there's really major three things. Number one is N-of-1 models, trying to have like true individualized prediction and or causality understanding of things at like truly.
So the risk mitigation piece of
truly at an individualized level, like I create something only for Max Scherzer, and like this is all the data from Max Scherzer the last 3 years, and this is what we found, kind of thing, and not trying to take aggregate summarized group data. Number two is at a public health level of really thinking, we know it works. Exercise, total body care, decrease sports socialization, do multiple sports, rest a little bit. We know that works, but the translating from the bench to community is not really working at all, to be honest, at this point. So really thinking about it from a public health, ecological level is number two. And then number three is thinking about trying to really understand the causality of the mechanism of injury, because we don't really know that at this point. We have ideas. Yes. We know that generally increased elbow varus torque to the medial elbow puts more strain on the UCL, and they generally get more injuries to the UCL than people with less. But we don't know if there's a rotational component to that. We don't know the level of that. Is it you could have two people with the same amount of torque, and one gets there really, really quickly, and one gets there slowly. Yep. And maybe those could be completely different mechanisms of injury and risk. Yeah. And so understanding that at a much more precise level through ways that really have not been used in sports, such as finite element analysis and getting more into like true in silico computer modeling with a biological informed data collection.
Yeah, I mean, it's a fantastic and exciting stuff because, like you said, it's hard to capture some of those mechanical changes, and you can put two people side by side, same amount of throws, same amount of, same biomechanical changes, and one's going to fail versus the other is not going to fail. And it's like, why did that happen versus biology and tissue type, right? So I think it'd be interesting to find out a little bit more about that as you guys kind of branch out into that research.
Yep.
One fun fact about yourself. What would be a fun fact about you
me?
That
So you'll never see this on my CV or whatever, but that I'm classically trained in ballet and vocal performance.
Really? That's amazing.
Yeah. So this came out of, I sang since I was 4. Of course, all the way through PhD, and then did music theater and all that. But part of being in musical theater and then in like more like classical like vocal performance is that learning how to dance, and then from that started learning about Lynn Swan, who did ballet, and then also he's such a great athlete, maybe I should do that. And so I did ballet and then jazz and tap from 7th grade through senior year of high school.
Pretty amazing.
Yep.
And you can do musical theater.
Yeah, that's a little bit farther to go, but
so if your career doesn't go the way you want it to go, we might see you on Broadway.
Nah, probably not at this point. But yes, but it's the singing part and all that. So
yeah, I couldn't carry a tune if you paid me. I can talk, but I can't sing. Well, Garrett, listen, I appreciate you taking the time today. I know you're very busy with your research and what's going on down there at Wake Forest. I look forward to reading more of your research and understanding more about the Extremity. I hope we can sit down and do something like this again in the future and kind of see where your research is taking you. And I hope that the people that are listening to this get a little bit of information about, what we need to do as practitioners, but also any consumers that are out there that are concerned about their sons or daughters that are overhead athletes, like what they need to do to make sure they stay healthy. So this is why we do what we do every day. I think we do it for the people, not for ourselves. So I appreciate you coming on today. It was great.
Yeah, thanks.
Thanks for listening to Behind the Sports Medicine Podcast. Follow us on social media and check out our website.
The information shared on this podcast is for educational and informational purposes only and is not intended as medical advice. Please consult a licensed healthcare provider for guidance related to your specific situation. We'll see you next week.